disorder and other diseases that affect the brain. All of those things are things that you wouldn't normally think, gosh, I guess I should have brain surgery, but we're hoping to get to the point where we can make it such that the risks are very small and the benefits are clear, and that you might want to pursue it given your condition or your symptoms. Parkinson's disease is where we have some of the most extensive experience and the most extensive studies to support its therapy. And one thing I'll say up front is that it really depends on the symptoms. You know, there's a lot of people with Parkinson's disease here today. You're either probably have it or you're here with a family member that has it, and what you'll know is that all of you have different symptoms. It's not like one person walks through the door and you say, yes, they've got Parkinson's disease. It could be any array of symptoms. And so when we think about any of the therapies that you receive, whether it's surgical or non-surgical, it really is a focus on what your symptoms are and can we improve your symptoms with a particular intervention. In this case, we're talking about surgery. So it's patient and symptom targeted therapies. So one of the things I'll say is a lot of patients will come up to me, and I think it's useful for you all to talk to each other. You should talk to each other, you should learn from each other. A lot of people say, well, I had a friend who had surgery and they did great. But when I talk to them, the symptoms that they have are not symptoms that I can help with surgery. And I'll say they might have done great, but their symptoms were different. And so it's hard to really extrapolate from one person to another. But the opposite also happens. A lot of people, some people will say, hopefully not a lot, you know, my friend had surgery, it didn't help them at all. And it might be because they were operated on for the wrong symptoms, and we normally wouldn't have operated on someone like that. So I do encourage all of you to speak to each other about your experiences if you have that opportunity, but also realize that speaking to someone who understands the procedure, understands the data, understands what symptoms we're looking for, what we can help is extremely valuable. Now, going back in history a little bit, I think it's useful to know where this concept of restorative neurosurgery comes from. We've got a lot of experience in this space, sometimes with people who aren't neurosurgeons. Walter Freeman was not a neurosurgeon, but it really gave the idea of psychiatric surgery a bad name because he just had a road show doing frontal lobotomies through the orbit, as shown there. But we won't talk about that too much. There are other procedures. Like Irving Cooper was a very well-known neurosurgeon, and he operated for a long time. In fact, I had, before I was here, I was in Los Angeles, I had the privilege, I guess you could say in a certain way, that he did something called cryosurgery. Before we did deep brain stimulation surgery, where and I'll tell you more about deep brain stimulation, but he would put a probe in, freeze a part of the brain in order to treat the symptoms, and create a focused lesion. He did that for many movement disorders, Parkinson's disease and dystonia, and I got to operate on a couple of his patients that he had done a cryothalamotomy for dystonia, and then I subsequently did a deep brain stimulator decades later. But Irving Cooper, a lot of this happens in neurosurgery. Things happen by accident. He was doing something called a mesencephalotomy, which doesn't matter what it is, but he accidentally caused a stroke, and the stroke, he was doing the mesencephalotomy for Parkinson's disease, which is cutting a part of the brain, but he caused a stroke of the anterior carotid artery, and it turns out it helped the symptoms of Parkinson's disease. So that became a therapy for Parkinson's disease, to go in and purposely cause that stroke. We don't do that anymore. And then Lawrence Lexell is really a big name in neurosurgery. He's passed away long ago, but anyone here heard of a gamma knife? So gamma knife is used for people mostly now with brain tumors or brain metastases, sometimes used for other diagnoses, but it's the most common use. But it's actually created to focus radiation energy onto a specific part of the brain. His thought was to create it for patients with Parkinson's disease, to create a focal lesion again, like Irving Cooper was trying to do, like Walter Freeman was trying to do, but using radiation. And we'll come back to this idea of focusing energy to treat diseases. We used to do this. We used to consistently damage the brain in a controlled manner to treat Parkinson's disease. And this is, I like this figure. It's from an old textbook, but every single one of those numbers are areas of the brain that neurosurgeons have tried to lesion or target over the last several decades to treat Parkinson's disease, and it's pretty much amazing. Like, there's no part of the brain that neurosurgeons have spared in trying to pursue a therapy for Parkinson's disease. But that is now we don't do that very often anymore. But why did all these techniques fall out of favor? It's basically because medicines came up. So when you get diagnosed with Parkinson's disease now, and I think Dr. Liss spoke about diagnosis and medical therapies, part of a bigger talk, but medicines came about, carbidopa, levodopa especially, basically put neurosurgeons out of business for a while, which is fine. I think you shouldn't have surgery if you shouldn't have to. So that's both true in the psychiatric space as well as the movement disorder space. But then what happened is, about 2.5 decades ago now, 3 decades ago, what we realized is that drugs can't fix everything. And in fact, drugs have certain side effects, like carbidopa, levodopa, although I don't think it's purely because of the drug, as the disease progresses, but you develop dyskinesias, you develop dystonias, you develop failure of response to the medication, wearing off unexpectedly, all the other symptoms that can happen with that the medications are not so good at controlling. And then we also had technological advances. So simply put, the ability to put electrodes in safely, relatively comfortably in a targeted spot in the brain and get a good outcome really transformed the field. Long before I was in practice, when people were doing pallidotomies, there was something called a pneumoencephalogram. For those of you who know your Latin well or can figure out all those. So pneumo is air, encephalo is brain, gram is picture. So it's basically we would inject air into the spinal, like a lumbar puncture or a spinal tap, inject air, see where the air goes in the head, take an x-ray, and that's how we targeted things. We're much better than that now. We've got MRIs that are very high resolution, so we can see where we're going, we can know exactly where we're going, which helps both surgery as well as the programming of our deep brain stimulation systems. So we still have ablative therapy in our armamentarium, and in fact there's a little bit of resurgence of that, but mostly neuromodulation or brain stimulation is where we focus our work. It's electrical, it's non-destructive, it's testable, we can turn it on, we can turn it off, it's reversible, but it is expensive, and there can be hardware failures, although over time with competition in the field, the devices have all gotten much, much better. All right, so deep brain stimulation, I mentioned this already, it's basically a pacemaker. It delivers electrical stimulation constantly to a very specific target in the brain. When we put these electrodes in, there's 3 FDA-approved devices in the United States. They are very similar in terms of the electrode arrangements, but they allow us to guide where we deliver the electricity in specific patterns. And my goal during surgery is to get the electrode in as good of a spot as possible. There's different ways to do that, and I'll talk a little bit about that. But it's also to get in the right spot, and then the surgery is not actually therapeutic in and of itself. You need a neurologist or someone else on the team to actually turn the device on and make it work. I had a running joke with the neurologist I worked with when I was in Los Angeles. I used to say that my part was the easy part. She has to do all the programming. I'm like, that's the hard part. She said, no, your part is the hard part. You got to do the surgery. My part is the easy part. Turns out we both need each other. So it's just not a therapy without having a good team. And so the title of this talk is the when and why. I think an important part of the when, besides when you have the right symptoms we're going to talk about, is to have the right team. When you have the right team is when you should do the surgery, and how we define team is different, but I will never implant someone if I don't know who's going to be managing their implant afterwards, as I shouldn't. Unfortunately, there are some surgeons who will just do an implant, and I don't think that's right. Likewise, your neurologist, whether it's within our system, but half of our patients are not from our system, should be able to trust in the neurosurgeon and have a dialogue. So I'm constantly in touch with all the neurologists that I am working with, getting feedback to know how my implants are doing, how my patients are doing, because that's what helps me improve my practice and my targeting. So that, I think, is a very important part of it. So this is a schematic, and it's a cartoon, but we don't put 3 electrodes in at once, but those are the 3 spots that we use for Parkinson's disease. And One is the thalamus, one's the subthalamic nucleus, one's the globus pallidus. So what are the symptoms that we treat? There's a couple different profiles that we treat in Parkinson's disease. I'm going to try and highlight what those are. But my short answer is, what do we expect with deep brain stimulation therapy? Well, one, it's not a cure. Two, it's not going to change your disease course. You're still going to progress. But what it will do is provide you more time in your best on condition. What do I mean by that? When you take your medications, I'll just say carbidopa, levodopa for simplicity, although it could be any medication. Most people feel it kick in when it does, about 30 to 30 minutes to 1 hour after the medication is taken. You feel like you're good, then you can have dyskinesias, or maybe you go straight into dyskinesias, and then you wear off. So you've got this up and down pattern throughout your day. This isn't quite, I'll tell you what this is in a second, but you're going up and down throughout the day, these motor fluctuations. But I'll ask people, do you have a good on time? And they'll say, yeah, sometimes I'll take my medications and I don't have dyskinesias, I'm not off, and I feel like I'm actually normal. So I tell people to imagine that normal state, normal in quotes, and what our goal with deep brain stimulation surgery is to give you more time in that best on condition. It's important to know that because it's the same, with one exception, which I'll tell you in a moment. The same symptoms that are treated with carbidopa, levodopa are the symptoms that we treat with deep brain stimulation. Meaning you're going to have less off time, so less rigidity, less slowness, less tremor. But we also will result in less dyskinesias, which are the extra movements, and less dystonia. The one symptom that will respond to stimulation that may not respond to medications is tremor. So I just told you about these people who are fluctuating, so more time in your best on conditions. So actually, let me talk about that a little bit more before I get to tremor. So the people that we will consider are those who, when they take their medication, it works consistently, but it kicks in, but then it wears off, every 2 hours, every 2 to 3 hours, you're going on and off, on and off. There are also people who the medication, sometimes you have dose failures, where you have unpredictable wearing off. So and if you have ups and downs, whether it's consistent ups and downs or inconsistent ups and downs, deep brain stimulation can help get you more time in your best on condition. Those patients with motor fluctuations, there are some patients who the medications can help, but you just have too many side effects. You just can't tolerate the medication, often being gastrointestinal, so nausea, sometimes we've seen everything from extreme fatigue or other reasons of intolerance. And I'll say that if we don't jump right to that, if you're with a good neurologist, there are strategies for how to ramp up the medications, and a lot of people, if you do it right, you can actually tolerate the medications if you're ramped in correctly. The last category that I started talking about, but I'm coming back to now, is people who have medication refractory tremor. If you have movement symptoms that do not, tremor in particular that does not respond to medications, that is one symptom that will respond to stimulation even if medications don't help them. So many of you might be thinking, well, I've got other movement symptoms, like I've got walking problems, I've got freezing of gait, or I have balance difficulty. You'll notice that I haven't talked about those because those usually we do not expect those to get better. The one exception is if your freezing of gait, your gait problems improve with medications, then it's probably improved with stimulation. Except that once your gait starts getting impaired, it usually progresses at a certain rate. And so you might those gait problems might become resistant to the stimulation, but still, it doesn't mean that surgery isn't the right option, but we just want to make sure that you understand it. So freezing of gait in general is a red flag for us if it's not responding to medication, balance problems, and then all the non-motor symptoms of Parkinson's disease. So cognitive issues, sleep issues, the psychiatric components like depression. Even though we do deep brain stimulation for depression, it's in clinical trials, but people get a little bit confused about that because deep brain stimulation depends on what part of the brain we put the electrode. It's a completely different part of the brain, so it's not like it's going to help with depression. Let me, I think, I'll go over this, then we'll pause for some questions. This is one of several randomized clinical trials that have been done for deep brain stimulation for Parkinson's disease. I'm going to focus on the bottom graph right here. Don't worry about how the study was done. But this is based on Parkinson's diaries. And color-coded, this is before a baseline, color-coded according to how many hours you're sleeping, how many hours you're immobile, how many hours you are this is sort of in between stage. This is good on time, and that's dyskinesia time. And what you'll see is this is in the brain stimulation group. After 6 months of brain stimulation, you have less time in the off state. You have more time in the on state, that's about 4.5 hours, and less time in the dyskinetic state. So it improves things. And then you look at this right here. This is the group that was randomized to just medication without the stimulation on. And it doesn't take a medical degree to see that these two distributions look exactly the same. And then up here is other changes from baseline in terms of multiple quality of life issues. So this is a summary. This is mobility, activities of daily living, emotional well-being, stigma, bodily discomfort, social support. You see cognition doesn't really improve too much, although there's some signal there. So this is what I was just telling you about, more time in your best on condition. So what does this tell us? And there's a lot of trials like this, and I'll give you a little asterisk at the end. When you are a candidate for deep brain stimulation surgery, you can go to the best neurologist and they can play with your medicines. But 6 months later, you're going to be pretty much the same as you were 6 months before. So once you're a candidate for deep brain stimulation, if someone tells you you're a good candidate for it, my recommendation is you should probably think about doing it. What do you lose by delaying it? You just lose the benefit of time of the therapy. The caveat to this is this was done, this study, I don't have the date on there, it's from a while ago, probably about 15 years ago. And there are new medications. So if you walked around the display there's all these new medications. And so it's not quite as simple as this anymore. In particular, if you're not seeing a movement disorders neurologist, before you get to brain surgery, I almost never will implant someone who's only being managed by a general neurologist, because the medication management for someone with Parkinson's disease is much more complicated than just carbidopa, levodopa. It should be someone who's thinking about what all the medications are out there and what we might be able to do. And I'll tell you, it's important because I tell this story of a patient from a long time ago, but it's just one example. It's happened several times. I've always seen patients either with neurologists that I work with very closely in the community or within my own center. There's one patient that we saw that had a lot of tremor and had Parkinson's disease, and he came to see me, and he was an artist. And he wrote a book, or it's basically a chronicle of his drawing. He had very severe right-handed tremor, and the book was called From Right to Left. And it was him teaching himself how to draw with his left hand, because his right hand had become so disabled from Parkinson's disease. And he became a really good artist with his left hand. And then we saw him, and we thought, gosh, this guy is just not being managed appropriately with medications. And the neurologist I worked with basically put him on a regimen and worked with him for a while. And we got a very kind thank you note about 6 months to a year later. He was drawing again with his right hand, because now he was actually being managed appropriately with his medications. And I didn't do surgery, so that's perfectly fine by me. I mean, if you can get managed with medications, why have surgery? But that's the important part, that if you get to the point, if you've tried the medications appropriately and you're managed by a good neurologist, you should have surgery. If you haven't gotten to that point in proper medical management, you should do that, because there are probably going to be opportunities. Okay, let me pause it. This is probably a good opportunity, just because we're talking about the indications, before I go on to a slightly more detailed part of the talk. Any questions about when we do surgery, or what symptoms we treat? Yes?
So, he's had Parkinson, or he's had the DBS since like 2013. We've been with Medtronic, sorry. We had Medtronic, and we've already had asked this question to his neurologist, but we've been seeing like every now and then, not consecutively, but like every 3 times a year, that he'll have like some sort of anxiety attack, and because of too much energy, I guess, from the device. So we've had to be able to like turn it off. Not a long period of time, but is there anything that causes or anything that has like a side effect from turning off the device?
No, so no. The question is about side effects of the stimulation, in particular anxiety. That'll actually be a good segue into my next slide. So thank you.
Yeah.
There's no long-term benefit from stimulation, so we don't change the course of disease. So likewise, turning the device off, there's no downside to it except that the symptom control that you might have gotten from the stimulation,
Right.
You lose that temporarily. But there's no downside to turning it off and on, and all the companies provide a patient programmer, so you can control your device through some mechanism, depending on what your neurologist or whoever's programming you allows you to do.
Yeah.
Now, I'm going to get into sort of anxiety and stimulation on my next slide, so I'm going to hold off on answering that. Yeah.
Of course, we're in my brain a month ago in July.
Yes.
I will tell you that this is the most amazing thing, because I noticed the difference right away, but everybody else, people that don't know, tell me there's something different. So it really does work. But I would take issue with what you said is no long-term benefit, because I've heard from the very beginning that the only thing that has a long-term benefit is the exercise. And as the first time I went back to my rock steady class afterwards, I did things I was never ever before able to do. I mean, it's like, so I mean, I don't know whether it's been helping or not, but I can do things I was not able to do because my left hand wouldn't do it. And
So
it does it now. So
that's a good comment. As those of you who've worked with me, I try to under promise and over deliver. But you know, so no direct disease modulation. Clearly a benefit in terms of quality of life and long-term benefit of the therapy. You know, we have people who've been implanted 10, 15 years, and you know they now there's rechargeable devices, but they keep coming back for battery replacements because they know the stimulation. So there is long-term benefit, but I don't think there's disease modification. But you raise a good point. You know, you'll probably hear multiple times today, and I'll say it again if you haven't. Exercise is the one thing that we think there's evidence for disease modification, meaning changing the progression of disease. And it's sort of an indirect benefit, but if we do the surgery and you're able to exercise more or participate in activities more because you have a more consistent therapy, then potentially there's a disease modifying effect, but it's not directly from the stimulation, it's just from enabling you to do other things. Yes?
Could you please repeat which conditions do not respond to deep brain stimulation?
It's a long list, just because the symptoms of Parkinson's disease are long. But in general, you know, freezing of gait, so walking difficulties, balance difficulties, especially if they don't respond to medications, are not going to respond to surgery. In general, we say that sleep issues do not respond, cognitive issues don't respond, and I say this a little bit hand wavy. There's, you know, people are looking at, you know, potential other benefits of the stimulation, but this is those are broad categories. I don't know if Dr. Liss, you want to add other things that don't respond to deep brains?
Any mood stuff.
Yeah.
Any non-physical, basically non-physical.
All the non-motor symptoms is generally what we think of.
Thank you.
At what stage of the disease do you recommend brain stimulation?
Really good question. So the question is, what state of the disease do we recommend brain stimulation? It's not the duration. So I've implanted people who've been diagnosed for only 2 years. I've implanted other people who've had disease for 15 or 20 years. So it's not a time duration. But there is a certain state, without getting into the technicalities, but people who meet the symptom profile that I described for you, that there's either motor fluctuations, the intolerance of the medications, But people who have a good response to medications, apart from those the refractory tremor patients, those are the people we want to implant. Now, there comes a time where you say, well, the medications respond well. I respond well to the medications, but I have cognitive issues, or I have, my gait. I really want to be able to walk. And that's where it becomes a bit more difficult, because we can provide a benefit, but it may not be the benefit that's meaningful to you. So there is a bit of a sweet spot. We definitely don't want to do if you can take medications and control your symptoms and have a consistent response, definitely don't need surgery, at least not with the current data. If you are so severe or so advanced that there are other debilitating symptoms that making your motor response more consistent, it makes you better but doesn't make your overall quality of life better, then you don't want to do it in that advanced state either. You want to be in that state where you do have good on response or good on condition and get better at that point. Yes?
As I understand it, please correct me if I'm wrong. Let's say that you have tremors on the right side and you get DBS. The electrodes go into the brain in a certain area.
Yes.
What if you eventually progress into where now your tremors are on the left side?
Yeah.
What happens to the brain?
So the Parkinson's disease does progress, and it usually, there's some asymmetry to Parkinson's disease, meaning one side is more affected than the other. Oftentimes, by the time people present, they have symptoms on both sides. Usually it's still different between the two sides. So I would say the majority, at least 75% of my patients with Parkinson's disease get both sides of the brain implanted at the same time. There are some people who get one side implanted because there's just so much asymmetry. And it's not uncommon for them to come back 2, 3, 4 years later and get the other side added to the system. So we implant the other side of the brain to get the other symptoms controlled on the side that has progressed.
Would you recommend that you wait until you get both sides not working?
Oh, no. Oh, so I'm very biased because I'm a surgeon. But I'm also very biased because I've seen the benefit of the surgery. People often ask me, like, should I wait? Is there a downside to waiting? There is. The downside to waiting more than anything else is losing that potential benefit that you would have gained in the time that you've waited. So if you're waiting 2 years, you say, well, I just want to see if I get symptoms on the other side so I can get both sides done. But there's 2 years where you might have had benefit from the stimulation. The other potential downside of waiting is, if you're older, you get older, other medical issues, and you might not be a candidate for surgery. You might develop other symptoms of Parkinson's disease that may preclude you from having the surgery, or you might have other medical issues. From a pure Parkinson's disease standpoint, there's no real downside because it's not neuroprotective. It's not changing your disease course. It's the functional benefits that we miss out on. Yeah, take 2 more questions and I'll keep going. Yeah.
From a surgery risk perspective, how do you measure success in terms of getting the intended result without unintended consequences? I don't know what metric you use for that. What are you seeing?
I'm going to get into the risks of the surgery in a little bit. And talk. I'm sorry?
I can wait.
Yeah, I'll get to that, and then because it is, I'll say, there are a lot of people say, well, what's the likelihood that it's not going to help? It's very, very, very low if you're selected properly and you're implanted in a good location. Now, it's possible that the electrode doesn't land in an optimal location, although with everything that we do. But we'll get into what the risks are, and that's a personal question if people are willing to undergo those risks, which I think are pretty controlled, but they're not zero.
The other part of that is what unintended consequences, like the stroke example you gave in one of the examples you showed in the pictures.
Yeah.
You can talk to it later on.
Yeah, I will. Yeah, and we'll talk about the risks and what they look like. There's one question here. Yeah.
What is the average age of persons who implant?
I have implanted people in their late 30s. I've implanted people with Parkinson's disease into their 80s. So it's average age is probably 60s because most people. So we have young onset Parkinson's patients who are anyone before the age of 50. It just depends. Depends on your overall health. One more question.
Just what does rehab look like after?
Rehab is a good question. You don't really need rehab per se, no targeted rehab, but a lot of people, I do want people to be active, and so that raises people often says like, well, what can I do after I get there? I'm gonna have a brain implant, can I like do everything I want to do? Yes. I have one patient, not Parkinson's disease, essential tremor, but who's an avid cyclist. I have another sort of patient who is a periodontist. I have another, there's only one patient, funny story, he's an older gentleman, Parkinson's disease, and I often joke, the only thing you can't do is deep sea diving and jump out of planes. He's like, no, but I jump out of planes on my birthday every year. I said, well, we're not doing so very little you can't do. It's the only person that never said no because of that reason. But this is a very highly technical slide, and I won't get into it, but there are two different targets that we use in the brain. One is called GPI, and one is called STN. There's a long debate. This is something that neurosurgeons and neurologists love to talk about. The main point is both of them get people better. So the UPDRS, which is the Parkinson score, gets better in both of them from the baseline to where they are at the end. And there's really no difference between the groups. But there is one difference between the groups, which is the neuropsychological examination. Subthalamic nucleus is a great target. It feels really good. It's fun to do during surgery because we get really good signals, and if you have tremor, it usually stops the tremor real quickly. And it is a great target. You're able to reduce your medications more when we target the subthalamic nucleus. But it comes out, and this is getting to your question, these neuropsychological effects, and it can induce sort of disinhibition, or doing things you normally wouldn't do, or anxiety attacks or other things. So I don't know his condition, but if I had to guess, I would guess that he's got a subthalamic nucleus implant, but I don't know. Globus pallidus has a less of an initial wow factor, because when you turn it on, you don't say, wow, that looks great, but very quickly, people end up in a relatively same position, a little bit less medication reduction with the globus pallidus. It's really a personalized decision. My practice has evolved. When I was at my former institution, we were about 80% globus pallidus, 20% subthalamic nucleus. Here, we're probably more like 60-40 between the two. It just depends on the neurologist you're working with. A lot of it has to do with the neurologist. I don't make that decision independently. Sometimes I'll make a suggestion if I disagree or if I think there might be an alternative, but usually it's based on discussion with the neurologist because they are the ones that have to take care of you and manage the symptoms. So surgery is not a simple process. It's not like you come in and see me and I say, great, let's do the surgery next week. There are multiple assessments. There's neurological assessments, there's cognitive and psychological assessments, there's neurosurgical, and then general medical, where it is a straightforward surgery, overnight stay in the hospital, but it's still a major stressor. So you have to be in good cardiac shape and all the other considerations. Then the surgery itself, we'll talk about that, but there's the brain implant, there's a generator implant for multiple reasons. They're usually done in separate days. In some occasions, even if you're having bilateral implants, we might do the two sides of the brain on separate days if we're concerned about your sort of cognitive baseline. There are different ways to do the surgery, but that can take anywhere from, some places will do everything in one day, which is not very common, or it could be staged over a couple months' time. And then, of course, programming comes afterwards. So it's often we'll say that patients are sort of like you're marrying into the family, because once you get implanted, we have to take care of you. You can't, it's not like you just go off on your own because it needs management. So who's a good candidate? We need to make sure you have a PD diagnosis. I think some of the people that have failed therapy often, I say often because it doesn't happen that often anymore, but at least not in my practice, but end up not having a different diagnosis. They've been misdiagnosed. They have something that looks like Parkinson's disease, we'll just call it Parkinsonism, but they didn't really have Parkinson's disease, and those people probably shouldn't have been implanted. So we need a confirmed diagnosis of PD. There's different ways to confirm that diagnosis. Clinical diagnosis, response to carbidopa, levodopa is probably the most important. So we do want to look at your medications and how you respond to it. we want to make sure that the movements are interfering with your quality of life, and not just that they interfere with your quality of life, but they are the principal factor that's affecting your quality of life. And that making them, addressing those would make you better. We want to make sure your MRI looks appropriate for what we want plan to do, that I can get to the target that I need to, medically suitable surgery, and then of course, you gotta want to do it. We don't strap people down to make them have surgery. And then, as I said, the staging of surgery. It's if there's bilateral cranial implants, it could be as little as 1 surgery. It could be as much as 4 surgeries. We usually do it in 2 surgeries, and then it depends on patient safety, your age, cognitive, psychological assessment, and then prevailing practice patterns. And I would say what that means is the vast majority of centers in the country will do the brain surgery and the generator surgery on 2 different days. Lots of different ways to do the surgery. We use a stereotactic frame, which is what you see up there. You might say, gosh, that looks archaic. It sort of is. It's been around for 50 years, but it's so good that we haven't had to evolve it too much. It's a little bit different now. But why is that there? That helps me know exactly where your brain is relative to your skull, so I can get the electrode where I need it to be. There's different ways of doing it. There's something called the next frame, which is there, which is mounted on top of your skull. But to do that, you get bony implants all around your head to localize it. And then there's this one, which is Starfix. I don't know where the X one. That is also, you need to have bony fiducials implanted on your head a week to 2 weeks ahead of time, and then we custom make the frame. I don't love the bottom 2 because although they seem like they're lower profile, you have to come in for an extra visit, for an extra procedure to put bony fiducials in, which for me, especially when people come from far away, it's yet another step to make them come in and do that.
Question real quick.
Yeah.
On the last slide, when you said 1 to 4 surgeries,
yeah.
Are those consecutive days?
No, they're usually staged out a couple weeks or a couple months apart.
Okay.
And then in the operating room, this is what we do. We have the patient sitting or laying in the bed, use an X-ray machine to look at where everything's are. We take pictures, getting the electrode into the precise spot. We record from the brain. Those are those little vertical lines are neurons firing in the brain. And then we do testing during the surgery to make sure we're in the right spot. So why do we do it that way? We do it because I feel like surgery is the best time for me to make sure that I'm in the right spot and that I get a good response to the stimulation, and that if I need to move the electrode right then and there, it is, I'll say, not ever having it had done myself, but done it to many people. It's scarier than it sounds, and most people tolerate it just fine. A lot of people are worried about waking up and not being able to be awake. Very, very rare. I've done well over 1,000 of these. Very, very rare for someone to not be able to tolerate being awake. And we've got a team, at least at our center, that we do this a lot, so everyone knows exactly what's going on. We know it's very predictable, and I think that predictability makes people feel a little bit more comfortable. So we do the awake testing so we can make sure we're in the right spot. I will say this was something fun that we did. We had someone, he really wanted to be able to play his guitar, so he brought his guitar to the afternoon.
That was at UCLA.
It was at UCLA.
Yeah, it was all over the news.
Yeah. It was all, it was fun. There are people who do the surgery asleep, and actually there's now an FDA approval for it to be done asleep with image guidance or image confirmation, meaning that we use basically a CT scanner or MRI during the surgery to make sure that we're in the spot that we planned for it to be in. I do that as well. Some patients just do not want to be awake. Most patients I find will say whatever you think is the best way for you to do it, which I think is probably the right answer. So I think if you're a surgeon, I would not make a surgeon do something that they're not comfortable doing. So I'm comfortable doing it both ways, but the most common way we do it is awake. There's advantages and disadvantages. Definitely more comfortable for the patient to be asleep with image guidance, but then we don't have the testing and confirmation to make sure that we're precisely where we want to be. Okay, and then programming we talked about. This is an older slide, but basically shows there's lots of different things. There's probably tens of thousands of combinations of programming and different devices have different ways of optimizing that, whether it's some of the devices will actually like listen to the brain, so look at the neuronal firing to tell you where to optimized stimulation. Some of them are image guided, which will tell you, where to get the best response, to program it in a certain way. And in other cases, a lot of people just will do what we call a monopolar mapping. They'll just go through the entire stimulation pattern or all the different contexts and figure out what might be best. Okay, so risks. We don't have a lot of risks, but we do have real risks. The thing that people worry about is that putting something in your brain, I'm going to cause bleeding in your brain, which is understandable. The rate of a symptomatic bleed is about 1%. So 1% chance that you get some kind of bleeding in your brain that causes some kind of symptoms. And then about half of those will have some kind of permanent deficit. Almost everyone gets better to some extent. No one, I haven't had anyone have a permanent debilitating deficit. But you can have a permanent residual, depending on where the bleed is. So that, we know about that. We've changed our techniques to a certain extent to how we do the approach, how we look at blood vessels to make sure that we're not going to hit blood vessels, but it can still happen. Very aware of that. The risk that we're actually more concerned about, not more, but is more common, is infection. So here's a wound breakdown. Happens, it says 5% there. Studies will say it's anywhere between 3 and 8%. I usually tell people about 3 to 4%. Either way, it's about the same in practice. People always ask me, what can I do to reduce the risk of infection? I'm going to say, I don't think it's what patients do. I think it just is something by nature of putting something in the human body that's not supposed to be in the human body. Bacteria will stick to it, it'll grow. So I think infections happen at the time of the surgery, not because of anything patients do. We do everything we can not to get an infection. Just have to be methodical. It's pretty rare, but once you get an infection, it's not a debilitating thing. It's a big bump in the road. Never had an infection inside the brain. It's always under the skin, but it does usually mean a surgery, remove the device, treat the infection, put it back in. Those are the big ones. So when you say, how do you judge the value, like the risk benefit? I'll say that for Parkinson's disease, probably 95+% of our patients get better, like I described for you earlier, and these are the risks. And it's a personal judgment about, how debilitating. Some people say, well, I'm living with it, I can deal with it, I don't want to take those risks. Usually by the time people come to me, they've been talking to their neurologist for a little while about it, they've sort of come to the idea that I think I need to have something done, and they're willing to take these risks. There's other risks there in terms of hardware failure, which is pretty rare these days. Stimulation-related side effects, so you see the mania, impulse control that are like anxiety, some eye deviations, abnormal movements. That's what we're trying to avoid by doing the mapping awake during the surgery. So this makes it look really bad, but overall, I'll say, part of why I love my job, and I hate when doctors complain about being doctors. They say, oh, healthcare. I love it. I love doing what I'm doing because I get to make people better. I do take a little bit of risk, but overall, we're really making people better. So I think, how do we optimize outcomes? I said this before, but I think it's so important. It's having the right people at the table, whether it's all in one center or your neurosurgeon working with knowing who your neurologist and working collaboratively to get the best care. Evidence-based care should do some of the evidence that we have there, and then being very standard about how we take care of patients. Again, because we do well over 100 implants per year, because we've got a system, every patient gets treated, we know exactly what we need to do. It's not like the nurses say, what did we do? Like, what do we need to do? Like, they know exactly what happens with our patients, and so it really helps streamline the care and get better outcomes. So some expectations. It's not a cure. Not everyone's a good candidate. You've already heard these names. It's only appropriate if tremor or the other, the motor fluctuations are a major source of disability. It doesn't work instantly. You need a multidisciplinary team, and there are those risks. I'm going to skip that slide for the sake of time. So focused ultrasound is another therapy that's come on. Remember I started with the idea that we can lesion the brain instead of doing deep brain stimulation. Focused ultrasound, remember I talked about focused radiation. This is another form of focused energy where we focus energy on a certain part of the brain in order to treat the symptoms of disease. It was originally developed in essential tremor by a good friend of mine, actually at UVA, University of Virginia, where I trained, Jeff Elias.
Go Hoos.
What's that? Yeah. And it works very well for essential tremor. So these are doing Archimedes spirals. You can see how the spiral goes from there to there. It's really impressive when you see it happen. Very good therapy. This is a study from essential tremor. I don't want to dwell on it too much, but this is the improvement that people get. So you can see 80 to 90% of people get a significant improvement with focused ultrasound. There's a little bit, that's how much people improve. There's a little bit of a rebound, but in terms of quality of life, people do extremely well. It's a good therapy. It's not perfect. We don't know how long the benefits last, but that's for essential tremor. I want to talk about Parkinson's disease. So this is for tremor-dominant Parkinson's disease. So the main application of the focused ultrasound is for people with tremor-dominant disease, not for the group that not for the most of the people who we implant, which are patients with motor fluctuations. And it's really interesting. Two things. One is, this is the group that actually got, so there's a sham group and there's a group that got treated. So here's the group that got treated. There's an improvement in the tremor. You'll notice there's these huge error bars. Error bars basically tells me how variable the response is across the group. So lots of variability. Another really interesting thing is that the sham group also got better. Not as much as the treatment group. So it should give you, it's very different than the responses we saw in essential tremor patients where it's a very clear improvement in that group. So it's not, and the other thing I'll comment about is when we go to meetings, people will spend have posters and talk about how I do focused ultrasound thalamotomy for Parkinson's disease and saying, I figured it out, this is how I do it, it's better than anyone else does it. If you read between the lines, what that means is everyone thinks that it's hard and everyone thinks that they figured out what it is and nobody's saying that they're doing the same thing. Everyone's doing it differently, which just means I don't think it's a great therapy. Now, does it mean it's not the right therapy? For some people, it might be the right therapy. They just, for some reason or another, they can't have a deep brain stimulator implant. They're not a good candidate. They've got tremors or dominant symptom. We can try it, but it's not my go-to therapy for Parkinson's patients with tremor because of this and because of the other symptoms that we saw. Because of the other patterns that I just told you about, people who's trying to, everyone's saying I do it better than anyone else because no one's doing it well. And then there's another, so focused ultrasound is, we're trying to create a lesion in the brain. You can also do it in the, remember I talked about targeting the GPI, the globus pallidus. You can do a pallidotomy also. So that's burning a hole in a part of the brain called the pallidum right there, and it can work. The thing is, we only do it unilaterally, so it's only for people with symptoms on one side, and it's only for people with motor fluctuations. And I'll say pallidotomy is very much fell out of favor because of the risks and complications of it, and especially the fact that you can't do bilateral treatment. So although this has been FDA approved for a little bit, the uptake has been very, very, very low. We've done one focused also on pallidotomy in the past 2.5 years since it got approval. It's just not something that we do very much. I think it's, unless there's a rare occasion that someone cannot get deep brain stimulation, I don't think it's the right therapy. So what you're hearing from me is that, focused ultrasound is an option. I don't think it's a first-line option for people with Parkinson's disease because I don't think it works as well for patients with tremor related to Parkinson's disease as it does for people with essential tremor. And I don't think a pallidotomy is a fantastic option in today's day and age with other options that are available. Yeah.
I just have a very quick question. Having had DBS, does that preclude any other future treatment that exists or might come along? Is there anything that it precludes?
Question is, does DBS preclude other treatment options? Not, maybe. So you can't get focused ultrasound after you have a DBS because we're sending ultrasound waves into the brain. So I should have said this earlier. Focused ultrasound is like holding a magnifying glass up to the sun and then burning a leaf. You're just focusing all the energy in one point. With the deep brain stimulator in place, those would interfere with the focusing of the ultrasound waves, so you can't do that. There are other trials that are nowhere near mainstream, like gene therapies for Parkinson's disease and other cell therapies for Parkinson's disease. Theoretically, you could be a candidate for those, but it depends on how those clinical trials are set up, and they have to go through clinical. It's going to be a long time before any of those therapies are mainstream.
I'll be too old, is what you're saying.
Yeah. I just don't know. I'm a optimistic pessimist when it comes to this. I want those studies to happen. We will participate in them, but I don't know how it's going to.
People ask me that since I'm just going to not do anything else.
No, you can't, because it's removable. It's reversible, right? So, you know, here I just the 3 treatments that we have. You notice I bolded and underlined everything that's sort of what you want. Medications, it's first line. They're often effective. It's non-invasive. It's testable. Meaning you can try a medication that doesn't work. You can get immediate relief. There's no programming involved. It's FDA approved. Minimal risk. Say that with a little bit of caution. Medication can cause side effects also, so you don't want to just stay on medication with side effects just because you think it's safer than surgery. At some point, quality of life matters. DBS is a great therapy. It is invasive. I will say, this is a little bit of an older slide I should update. If we say DBS is invasive, focused ultrasound is not. Focused ultrasound is invasive also. We're putting energy into your brain and we're causing a lesion in your brain, so it's not without risk. And it does give good relief. So, I mean, these are good therapies, but really, in my world, again, just like I talked about the fact that you need a good neurologist, a good neurosurgeon working together, you want to go to someone who does both procedures. I don't have a vested interest in trying to sell you a product. I'm not trying to sell you one deep brain stimulation or product or another. I just want to help you. If my help to you is to say, I don't think you should have surgery, fine by me. But also focus ultrasound. I do focus ultrasound and I do deep brain stimulation. I just want to do what's right for you. And what's right for you depends on a lot of factors that are beyond anything I've talked about in this talk. It's for personal factors as well. I would like to end with this slide, which is just the expectations of the surgery. And then I'll take further questions. Thank you.
Dr. Crowley?
Yeah.
What do you think of DBS, adaptive DBS, I should say?
So adaptive DBS, let me share with everyone what that is since I didn't get into it. I said that there are some deep brain stimulation systems that can listen to the cells or the firing patterns in your brain. One company has that device right now. Right now it hasn't been able to be used for any purpose except for some maybe guiding programming, maybe something like that. Adaptive DBS is the idea that, well, is there a biomarker in your brain that tracks your disease? So when your symptoms are more severe, does that biomarker change and tell the stimulator when to turn on or when to turn off? There's been one good study of adaptive deep brain stimulation used for the subthalamic nucleus that have positive results. The positive results are that it's non-inferior to standard deep brain stimulation therapy. And there's a hint that it might be better than standard deep brain stimulation therapy, although it's not proven to be better. So I don't think it's worse. I think it's compelling. I think it's really interesting. It definitely does reduce the amount of battery that is required because the stimulator is not on as much because it turns on and off. I actually think there's a project that we're working on. So yes, I don't think it's worse. I think it might have some advantages, but I think time will tell how it works out. I'm actually more excited about some work that we're doing that's inspired by animal models, believe it or not. Something in animals is actually being translated to humans, which doesn't seem to happen very often. But one of my collaborators who's at Carnegie Mellon in Pittsburgh has shown in animal models that you can use different patterns of stimulation for deep brain stimulation and have some long-term benefits. So just deliver bursts of stimulation, then turn the device off, and you can have long-lasting benefits, for a day. So maybe all you need is like an hour of stimulation a day, and you get benefits. And we're running a study right now to look at that pattern of stimulation. Time will tell, and more experience will tell how useful it is or how different it is. But it's under FDA consideration right now. I think it'll come back as an option, but not as a superior alternative with the current data and the current techniques. Yeah.
What could you tell us about cost?
Cost. So it should be covered by your insurance, first of all. So cost is hard to know. Cost from a hospital perspective, it costs us about $70,000, $75,000 to do the surgery because mostly driven by the implant costs. to talk to your deep brain stimulation company representatives. But that's the major cost. Depending on what your insurance is, what I've described for you are all approved indications, and all major insurance carriers, including Medicare, cover the insurance. So this depends on your insurance program.
Medicare doesn't cover it?
Medicaid?
Medicare.
Medicare absolutely covers it, yeah.
$300 deductible with Medicare.
Would you be willing to share your slides?
Yeah, they have, I'm happy for them to share this. I'll have the apps, yeah.
Thank you.
For the top of the brain surgery, is there any reason for it to move or migrate?
Do the leads migrate? So, we're putting leads precisely in the brain. That's why we wake people up. The new system, with the current systems, I've never is a very strong word. I don't think I've ever seen lead migration with the current anchoring systems.
Have you seen that with the older ones?
I also haven't seen it with the older ones, although I've definitely seen implants from other surgeons like, oh, I don't know what happened, the leads migrated, can you fix it? I wonder if they ever got in the right place to start with. Or they had lead migration because it wasn't anchored correctly.
Yeah.
We do get a fair number of people who come to us asking, are my leads in a good place? Can they be revised? Can they be put in a better spot? And that's a reasonable question, but it's hard to know without seeing the imaging. But yeah, that can happen. Yeah. Yes.
Is it true that if a new technology comes out, these things are programmable for Bluetooth, so I don't have to have another surgery? If there's a better way to deliver those signals at a different time, would that be possible?
It depends on, each manufacturer has a different, but most of them have sort of locked features that they can unlock once they get FDA approval for. Sort of like a car. Like we've got a lot of stuff on our car that they don't want us to use, but it's there. Yes.
How do you decide which of the three companies to go with?
Someone had to ask. So the question is, which of the? So I use all three. I will be very honest. When I show up to the operating room, I don't remember which one I'm using until I see which company representative is in the room, and I say, oh, we're doing Abbott today, we're doing Medtronic. Like it doesn't make any.
Who decides?
Yeah, get to that. Okay. So from a surgical perspective, it makes no difference to me. How do we decide? There is a bit of it. So all of this, I'll say first of all of the systems work. They are all FDA approved because they all provide therapeutic benefit. I truly do not believe that any one of them is superior to the other in terms of how well they work. But they have other bells and whistles about it, right? So the Medtronic system, for example, has the sensing. So it, could it go into an adaptive stimulation and provide potentially better benefit? Maybe. The Boston system has image-guided programming, and is image-guided programming going to be better? Is it faster? Possibly. The Abbott system, and Boston Scientific had the only rechargeable device. Now, Abbott system has the rechargeable device that you only need to recharge once every 6 weeks, which is crazy long amount of time between charges. But they also right now offer remote programming, which means that you can log in over telehealth and have your stimulator adjusted. So every one of them has different things. So when we have people who are coming from far away, we'll say, well, maybe we should get the Abbott one. They have to come in for a couple visits, but then we can maintain them from a distance. Other people, it's a decision based on specific factors of the patient. The number one thing, to finally answer your question, is what the neurologists prefer. Because the neurologists are the ones who have to program the device, and they have to manage the patient, and if they want a certain device, I'll do what they want. And they have different reasons. Some of them really like the image-guided programming, some of them like the sensing, some of them like the remote programming. Most of the neurologists I work with use 2 out of the 3 companies for some reason or another. But I think you can't really go wrong.
I know some of you might have additional questions, but just in the interest of time, it is 1:45, so.